everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the cardiology, that is the rheumatic fever. So, if you see this particular rheumatic fever, it is the disorder where the individual will have an inflammation in multiple systems in the body. And this is an acute recurrent inflammatory disease. Right? It's an acute recurrent. This point is very, very important. Right? That is recurrent. So it's an acute recurrent inflammatory disease. And this rheumatic fever, it mainly seen in children. Right, it is mainly seen in children of age group 5 to 15 years. Right, of age group 5 to 15 years. Okay, and this typically occurs 1 to 5 weeks after a group A beta-hemolytic infection. Right, it occurs 1 to 5 weeks after group A beta-hemolytic streptococcal throat infection. Alright, and this particular rheumatic fever, it occurs as a result of a immunological hypersensitivity to streptococcal antigen. Right, it occurs due to immunological hypersensitivity to immunological hypersensitivity to the streptococcal antigen. And please remember, rheumatic fever, it is not a communicable disease. And this rheumatic fever, it is a type 2 hypersensitivity reaction. Right, it is a type 2 hypersensitivity reaction. That is what is your rheumatic fever. Now, what is the pathophysiology for the development of rheumatic fever? So, if you take the pathophysiology for the development of rheumatic fever, it is mainly the cross reactivity. Right, it is mainly the cross reactivity of host anti-streptococcal antibodies to cardiac antigens. So, cross reactivity of host anti-streptococcal antibodies against the cardiac antigens. Right, against the cardiac antigens. So that is a pathophysiology of the rheumatic fever. So basically, it is a microbe initiated autoimmune reactivity. Right, it is a microbe initiated autoimmune reactivity. Okay, that is what is the pathophysiology in the rheumatic fever. So what happens here is the individual is infected with group A beta-hemolytic streptococcal infection. right? The individual is infected with group A beta-hemolytic streptococcal infection. Now, within the cell wall of, right, within the cell wall of the group A beta-hemolytic streptococci, you have the presence of the M protein. Right, you have the presence of the M protein. And this particular M protein of the streptococcus, against this particular M protein, the individual will form the antibodies to kill the organism. The antibodies which are formed against the M protein, they cross-react with the connective tissue component. Right, they cross-react with connective tissue component. Okay, which particular connective tissue component? That is, right, that is N-acetylglucosamine. Right, that is N-acetylglucosamine. So the antibodies which are formed against the M protein of the streptococcus, they cross-react with the connective tissue component of the same individual. And which particular connective tissue component? That is against the N-acetylglucosamine. And if you take the incidence of the rheumatic fever, it's an acute immunologically mediated multi-system inflammatory disorder. Please remember this. Right, it is a multi-system right, it is a multi-system inflammatory disease, and this occurs few weeks after an episode of group A streptococcal pharyngitis. And the incidence is that the studies have shown that 3% individuals with untreated group A beta hemolytic streptococcal throat infection, they develop this rheumatic fever. Okay, so 3% individuals. Right, 3% individuals with untreated group. Right, with untreated group will develop this rheumatic fever. Okay, and it is secondary to the pharyngitis. Right, it is your rheumatic fever, it is secondary to group A beta hemolytic streptococcal throat infection or the pharyngitis. Please remember, the rheumatic fever only follows throat infection, but it does not occur or it does not follow the skin infection. Right, it does not follow the skin infection. Okay, so that is a very important point regarding the rheumatic fever. Whereas, which particular condition follows both throat and skin infection? The condition which follows both throat and skin infection is post-streptococcal glomerulonephritis. Right? So, post-streptococcal glomerulonephritis, it follows both throat and as well as the skin infection. Alright, next. Then, you see a question here. True about the rheumatic heart disease and rheumatic fever is caused by group A streptococcus, caused by group B streptococcus, carrier have high risk of developing rheumatic fever, carrier have low risk of developing rheumatic fever. M5 protein cross reacts. Now, let me tell you, the carriers, they have low risk of developing rheumatic fever, and it is caused by group A beta-hemolytic streptococci, and it is your M5 protein cross reacts. So these are all the options which are the answers for this particular question. Next, then you take the manifestations of the rheumatic fever. True about acute rheumatic fever is chorea, erythema nodosum, arthritis caused by antecedent group A hemolytic streptococcus infection, carditis. So for this rheumatic fever, we have a criteria, and that particular criteria is called the Jones criteria. Right, that particular criteria is called as the Jones criteria. And in this Jones criteria, we have the major criteria and then we have the minor criteria. See, this is the older classification of the criteria according to Jones, that is major and as well as the minor criteria. Right, so this is the older classification of the criteria. According to the major criteria, right, we have the joint involvement, that is J. O stands for myocarditis. In the Jones, N stands for nodules, that is subcutaneous nodules. E is your erythema marginatum. S is your Sydenham's chorea. So this will be the major criteria. And what will be the minor criteria according to the Jones? C-reactive protein is elevated, presence of arthralgia, fever, there will be elevated ESR, there will be prolonged PR interval, anamnesis of rheumatism, and then leukocytosis. These are the minor criteria according to the Jones. Now, but this is not being followed in the recent guidelines. According to the recent guidelines, the entire population is divided into two groups. One is the individuals with low risk rheumatic fever. Second, the individuals with the high risk rheumatic fever. Now, what do you mean by the individuals with low risk group and as well as the high risk group? Let me tell you. See, now any individual or a group of population, right? Any individual or a group of population where the incidence of rheumatic fever, if it is less than, right, if it is less than 2 per 1 lakh school aged children. Right, less than 2 per 1 lakh school aged children. School aged children in the sense around 5 to 14 years. Or, right, or if you take any age group, all age prevalence right, all age prevalence less than or equal to 1 per 1000 population, right, less than 1 per 1000 population per year. So if this is the incidence in that group of population, right, school aged children less than 2 per 1 lakh school aged children per year, right, per year. And if you take all age prevalence less than or equal to 1000 population per year, that group we consider it as the low risk, right? But anything above, we consider it as the high risk patients for rheumatic fever, right? Anything above we consider high risk patients for rheumatic fever. Now, if you take the major criteria, Major criteria, it is slightly different in low risk population than compared to that of moderate to high risk population. What are the differences and what are the similarities? I will explain you. See, the similarities, if you see carditis, and you take the skin manifestation, that is subcutaneous nodules, and CNS manifestations. Okay, and another skin manifestation is erythema marginatum, and then the presence of the Sydenham's chorea. Right, the presence of the Sydenham's chorea. See, these manifestations, they are same in low risk population and as well as moderate to high risk population. Right, these manifestations are same in low risk group and as well as moderate to high risk group. Then what is the difference? The difference is about the arthritis. In low risk population, only polyarthritis is taken as a major criteria. Right, polyarthritis only. Whereas in moderate to high risk population, regarding the arthritis, even if it is monoarthritis, that is sufficient. Right, even if it is monoarthritis, if it is sufficient for the major criteria in case of high risk population. Or there can be even polyarthritis. Right, there can be even polyarthralgia. Right, there can be even polyarthralgia. So this will be the major criteria. Right, so in low risk population and as well as high risk population, carditis, subcutaneous nodules, erythema marginatum, Sydenham's chorea is same, but the difference is only regarding the joint manifestations. In low risk population, polyarthritis only, whereas in moderate to high risk population, polyarthritis is not required. Even if monoarthritis is there or even polyarthralgia is there, that is also sufficient to be taken as the major criteria. See, what is the difference between polyarthralgia and polyarthritis? In case of polyarthritis, within the joint you have all signs of inflammation. Right, you will have all the signs of inflammation within the polyarthritis. Whereas if you take polyarthralgia, the individual will have only the pain. Right, the individual will have only the pain in case of polyarthralgia. Then, after having discussed about the major, you see the minor criteria. So, if you take the minor criteria, what are all the minor criteria? I will tell you first the similar things in low risk and as well as high risk. That is the fever. And how much should be that fever? Fever should be more than 38.5 degrees centigrade. This is same whether it is low risk or high risk. This minor criteria is same. And apart from that, the presence of the prolonged PR interval. Right, prolonged PR interval. Even this is also same in the high risk population. Right, even this is also the same in high risk population. Okay, but what is the difference? What are the differences? In case of low risk population, it is polyarthralgia. Right, it is polyarthralgia in low risk population. Whereas in high risk population, it is monoarthralgia. Right, low risk population, polyarthralgia should be there. Whereas in high risk population, even if monoarthralgia is there, that can be taken as the minor criteria. Then coming to the ESR, that is a marker of inflammation. ESR should be more than 60 mm in first hour in case of low risk population, whereas ESR, right, even if it is more than 30 mm in first hour, right, even if it is more than 30 mm in first hour, we consider it to be the high risk criteria. Then followed by that, the C-reactive protein. The C-reactive protein, whether it is a low risk population or whether it is a high risk population, it should be more than 3 milligrams per deciliter. Right, it should be more than 3 milligrams per deciliter. Okay, right. So that is about the C-reactive protein. Okay, so the only difference is what now? The joint involvement and as well as ESR. That is the difference between the low risk population and as well as the high risk population. Then followed by that, coming to the essential criteria. Essential criteria for rheumatic fever is number 1, the ASO titer. Right? ASO titer should be more than 200 international units per ml. Right? Should be more than 200 international units per ml. What is ASO titer? That is anti-streptolysin O titer. That tells you the individual has, right, that tells you that the individual has or had a recent streptococcal infection. Right, a recent streptococcal infection. Okay, next, then followed by that, you take the throat swab culture. Throat swab, it may be positive or it may not be positive, because your rheumatic fever is developing almost like 1 to 5 weeks after the group A β-hemolytic streptococcal throat infection. Then now let me discuss the criteria. See, the criteria is slightly different depending upon the clinical scenario. What is that? I'll tell you. See, in case of the primary episode of rheumatic fever, that is the first episode of rheumatic fever, what should be the criteria? In the first episode of rheumatic fever, there should be 2 major, right, or 1 minor. Right, 2 major or 1 minor, and 2 minor manifestations. Okay, so 2 major or 1 minor, and the other thing is 2 minor, right, and 2 minor manifestations plus evidence of, right, plus evidence of the preceding infection. Right, what is the evidence of preceding infection? The ASO titer being elevated. So if this is satisfied, we can consider it as rheumatic fever in primary episode. Okay, now you take the second scenario, recurrent attack of rheumatic fever in patients without established rheumatic heart disease. What will be the criteria in this scenario? And almost the same, that is 2 major plus 1 minor, or, right, it should be or, right, or 2 minor manifestations plus evidence of recent streptococcal infection. That is in the clinical scenario without established rheumatic heart disease. You take the next, recurrent attacks of rheumatic fever in patients with established rheumatic heart disease. In patients with established rheumatic heart disease. In this scenario, two minor manifestations, right? Two minor manifestations plus evidence of preceding group A beta-hemolytic streptococcal infection, right? Plus evidence of preceding group A beta-hemolytic streptococcal infection. If that is there, then we consider it to be a rheumatic fever. That is in which scenario? In patients with established rheumatic heart disease. In patients with established rheumatic heart disease. Then you take in a scenario of rheumatic chorea. In patients with rheumatic chorea, one major manifestation or evidence of group A beta hemolytic streptococcal infection is not required, right? At least if one major manifestation is there along with the Sydenham's chorea, then also we can consider it to be a rheumatic fever. Whereas if the individual is having chronic valve lesions of the rheumatic heart disease, see, most of the times in our day-to-day practice, what we see is this scenario. Chronic valve lesions of the rheumatic heart disease, right? And almost patient presenting for the first time with pure mitral stenosis or mixed mitral and as well as aortic disease. In these patients, you do not require any other criteria to be diagnosed, right? The patient do not require any other criteria. Okay, so that is about if the patient has the chronic valve lesions of rheumatic heart disease. Okay, so this is about the criteria to diagnose rheumatic fever depending upon the different clinical scenarios of rheumatic fever. That is primary episode of rheumatic fever, recurrent attacks of rheumatic fever without established rheumatic heart disease, recurrent attack of rheumatic fever in patients with established rheumatic heart disease, rheumatic chorea, and third one is chronic valve lesions of the rheumatic heart disease, right? Now, followed by that, let me take up the discussion of the individual manifestations. So, if the question is asked, what is the most frequent manifestation in rheumatic fever? That will be your arthritis. So, arthritis, it is present in almost 75% of patients. Right? Arthritis, it is present in almost 75% of patients. And this will be the most, right? This will be the most frequent major manifestation, right? And any joint may be affected, but the most common joints which are affected is the large joints, right? And what are these large joints which are commonly affected? The large joints which are commonly affected include the knee, ankle, then elbows, and then followed by that wrist. So these are the joints which are commonly affected. And please let me tell you, small joints of the hand and legs, right? Small joint involvement is rare in patients with the rheumatic fever. Small joint involvement will be there in case of rheumatoid arthritis, not in rheumatic fever. And this particular arthritis, it is migratory in nature, right? It is migratory in nature. That is, several joints are involved in quick succession and each for a brief period of time. Like for example, you take the knee joint is affected and you will have all the signs of inflammation within the knee joint for nearly around 1 week. and all the signs of inflammation will subside within the knee joint. Then followed by that, the arthritis will start within the ankle joint. And there also the signs of inflammation will be there for nearly around 1 week. Followed by that, it will subside and then it shifts to your elbow joint, then to the wrist joint. So this is what is called as the quick succession, right? And inflammation of any joint subsides spontaneously within a week, right? And the entire bout of polyarthritis rarely lasts more than 4 weeks. So they spontaneously subside within 1 week, right? Rarely it may be up to 4 weeks. And the resolution, whatever is there, right? Resolution is complete with no residual joint damage. Okay, so there will be no residual, right? There will be no residual joint damage, right? And a striking feature is dramatic response to salicylates. Right? Dramatic response to salicylates. That is a very important point. These patients, they'll have a quick response to the salicylates, right? And this particular arthritis, it develops within, right? It develops within 2 weeks of development of rheumatic fever, right? And the arthritis, what you will have is a non-erosive arthritis, right? The arthritis what you will have in rheumatic fever is non-erosive arthritis, but rarely the deformity can happen, right? Rarely the deformity can happen, and that particular deformity we call it as the Jacquard's arthropathy or Jacquard's arthritis, right? That is called Jacquard's arthritis. Right? That is called Jacquard's arthritis. Okay. And let me discuss few points about this Jacquard's arthropathy. See, it is a deforming non-erosive arthropathy. Right, it is a deforming non-erosive, right, a non-erosive arthropathy which is characterized by ulnar deviation of the 2nd to 5th fingers, right, which is characterized by ulnar deviation of 2nd to 5th fingers. Okay, that is what will happen in Jacquard's arthropathy, right? And that too, which particular joints of 2nd to 5th fingers? That is metacarpophalangeal joint subluxation will be there, right? Metacarpophalangeal joint subluxation occurs. Right, metacarpophalangeal joint subluxation occurs. That is what will happen in patients with the Jacquard's arthropathy. Now, what did I tell you? The drug of choice for the arthritis in case of rheumatic fever, it will be your salicylates, which is nothing but aspirin. And secondary to this aspirin intake, the individual may develop Ray's syndrome. And you need to know what is this particular Ray's syndrome. Let me discuss this. See, Ray's syndrome is a clinical scenario where there is rapid worsening brain disease. right? It is a scenario where there is rapid worsening brain disease. And the symptoms of Ray's syndrome include the development of vomiting, right? Development of the personality changes, and then confusion, then development of seizures, and finally loss of consciousness, right? So this will be the symptoms of the Ray's syndrome. And apart from the brain disease, there is also development of liver toxicity. Liver toxicity also occurs, which will progress or where the individual may have the jaundice. Okay, so there is also hepatotoxicity. So brain disease and as well as the liver toxicity, right? And because of the brain disease, death occurs in 20 to 40% of those affected, and about a third of those who survive are left with a significant degree of brain damage. So mortality, if you see, right, mortality is around, right, mortality is around 20 to 40%, right? And what exactly is the cause of the Ray's syndrome is unknown, but this Ray's syndrome, it usually begins, right, it usually begins shortly after the recovery from a viral infection, right? It occurs or it begins shortly after a recovery from after a recovery from the viral infection. And what is that particular viral infection? Such as influenza, and chickenpox, right? Such as influenza and chickenpox. And secondary to this viral infection, in almost like 90% of cases in children, they are associated with aspirin use, right? Secondary to this viral infection, the children have taken this aspirin. And after intake of aspirin, the individual has developed Ray's syndrome. Okay, when does this begin? It usually begins shortly after the recovery from viral infection such as influenza or chickenpox. And what is that they have taken for the recovery of viral infection? That is the aspirin or the salicylate use. So that is about your Ray's syndrome.